Welcome to Orthodontic Smiles, the podcast designed for all dentists and their staffs who practice orthodontics. This podcast is brought to you by the American Orthodontics Society. Let me introduce to you Dr. Juan C. Echeverri. Unless you're a member of the American Orthodontics Society, you might not be familiar with his name. But those of us who are truly respect this man. From his beginnings as a maxillofacial prosthodontist at the prestigious MD Anderson Cancer Center, he saw the need to incorporate orthodontics into his prospering Houston practice. He sought out the American Orthodontic Society to get that training, and he never looked back again. All of the previous skills allowed him to develop new and innovative techniques to treat some of the most difficult orthodontic cases without surgery or extractions. He is so admired by the American Orthodontic Society, they elected him the president and later selected him as a board examiner for the prestigious Academy of Diplomates of the American Orthodontics Society. Let me welcome Dr. Juan C. Echeverri. Orthodontic Smiles tonight is going to welcome Dr. Juan Echeverri. It might not be a name that you hear very often unless you're a member of the American Orthodontic Society, since he's been a past president and he's been on the Board of Examiners of the American Orthodontic Society, Board of Diplomates. But I want to introduce you to a man that I respect tremendously. He's one of the stars of the American Orthodontic Society, associate instructor of the American Orthodontic Society. So I think you're going to enjoy this podcast because he's got so much to offer. Welcome to Orthodontic Smiles, Dr. Juan Echeverri.
Hi, Ed. How are you doing today?
Doing great. I'm even better because I've got you on our podcast. Juan, let's get everybody started here and help them understand. How did you get started in orthodontics? You were a prosthodontist before you started doing orthodontics. So help us understand how you got started doing this.
Well, the interesting part of my story is that I first had an American DDS in Colombia, and part of our training involved bending wires. If you're not good at bending wires, you got thrown out of school. So that kind of started me with the bending. And then in my last year, I got pulled out of the clinic and I was assigned as a monitor to help the graduate students in orthodontics. After that, I went on to do graduate studies at GPR, and we had some orthodontic training there. So we learned a little bit there. Then we went on to LSU, and in pros at LSU, we also had minor classes in orthodontics. So I had a little bit here and there, but I only really got a really good training when I came to the AOS with Dr. Garrity, and he basically gave my orthodontic knowledge a structure. So following that, I tried to learn under every single instructor we had in the AOS to create the knowledge necessary to be able to carry out this beautiful field of dentistry that we do today.
Well, how did you hear about the AOS? Were you in school, or had you been in practice for a while?
I was in practice, and I actually had a doctor in our office doing orthodontics, and we were having some management issues, so I became an assistant for her. But there was not enough of her in the office to handle all the patients. And so I realized that I had to go out and learn because I had no idea what was going on. In spite of what I had learned before, I had no idea how to take over patients if I had to. So I got a pamphlet. I looked at the pamphlet. I said, I'm going to take a bet on these people, and I'll take a course, and hopefully it pays off. And that was quite a few years ago. Seriously, I started in 2005, and I can't regret a second of it.
So it really did pay off for you. It is something we can learn, isn't it? It is not, a lot of times, the GPs and the pediatric dentists out there kind of look at the American Orthodontic Society and say, how can I learn orthodontics? It's just not something that you have to learn that in school. You have to learn that as part of an orthodontic graduate program. That is not true, is it?
It is not true. The beauty of the AOS and the way that it is structured was structured when I was a student, and it is now, is that we can start from a very basic, this is a bracket, this is a tooth, and then we start building up the diagnosis, the treatment plan, who to treat, how to treat, when to treat, who not to treat, and who to refer. So it's a really complete package. As everything in life, you're going to get out of it what you put into it. But we have some amazing people that teach great things. So if you apply yourself, you can become an amazing practitioner of this beautiful field, as we have, because we have so many fantastic practitioners of the field of orthodontics in our society.
Yeah, and when you first start doing this, I mean, we all started somewhere, and I'm not going to say it's the easiest thing in the world, but when you start it, you have apprehensions, of course. But the American Orthodontic Society has a mentorship program where we kind of help you through any case that you might have problems with, and our senior instructors are just fantastic. So you never feel uncomfortable learning a trade that you've never done. If you're a practitioner and you're out there doing implants, I mean, it would be comparable to that, would it not?
I think that it's actually better. I know many of our instructors have their groups for their students, and they are welcome to send the cases in, have them monitored, look at them. I have several of my colleagues that send me their cases, their images, their progress, and I'll make observations and I guide them through the whole process. So I think that it's better than what it would happen with other fields. I also practice in other fields, and I don't get the same support that I get through the AOS. It's just amazing how we help each other.
Yeah, and we know we've been through it all ourselves, and so we know what the student is going through. So we're out there for them and helping them. Now you're kind of unique, Juan, because you're married to a lovely lady who I've already interviewed on Orthodontic Smiles, and that is Elsa Echeverri, a pediatric dentist, very, very capable and a wonderful lady, and knows orthodontics and pediatric dentistry like the back of her hand. So she's been a wonderful adjunct to your practice as well.
It's amazing having my wife working with me. So not only are we husband and wife, but we are also partners in our business. She gets to see the part of the population that I have struggled with. I love to play with kids, but I don't like to treat them. But at the same time, we have this ability to reach to a very young population. I love the part of diagnosis and treatment plan, so I can do that part, and she loves the clinical part, so she can carry that part out. And as the cases and the patients progress and they get older, I can take over and handle that part of the practice. So it's a synergistic relationship that really helps us help all of these patients throughout their life.
Well, how does it work? Is she the one who does the early treatment in the practice, and she's a pediatric dentist and seeing them very young? And does she kind of refer them over to you in the general practice arena, or does she carry them all the way through?
The way we have a really unique setup. We bring the patients in, she'll see her patients, and then we'll get all of the appropriate records. I love the part of diagnosis and tracing and that, so I work up the tracings, work up the treatment plan, then we discuss how we want to treat them, and we create a template, and a template like I sent you the other day. So we have these templates that say this is what we want to do, this is the diagnosis treatment plan. And then she goes and works through a beautiful phase one. Now when they go into that, they start getting all the bicuspids and all, like I call all the extra 6 to 12 teeth that don't know where they want to go, then I will take over the case if it needs that phase two. If the patient is older, then she'll send them straight to me.
Gotcha.
So it works really beautiful. She sees that beautiful young age. She's got the personality to see them very well. I get them when they're older.
That's good. That's good. And you alluded to the fact that you sent me the other day your treatment planning protocol. And I was so impressed by that because it's all computer generated and it brings together all of the different aspects of a treatment plan and puts it all on one or two sheets of paper so that you can really look at it and say, okay, this is what I want to do. This is what it's showing me. It really is unique, and I think you need to publish that.
I hope Greg Caniso hears us and we can work through. I think that's a good idea. I had not thought about it that way, but I think we can make it available to whoever wants it.
Yeah.
So that they can run with it.
It really is good, and that's one of the nice things about being the American Orthodontic Society. We collaborate between each other as practitioners, as instructors, as associate and senior instructors. We love to learn from each other, and you are really one of the reservoirs of learning that the American Orthodontics has. Well, how has orthodontics changed your practice? I mean, you've introduced orthodontics into your practice, and obviously Elsa is so much a part of that. How has it changed the whole aspect of your practice?
If I were to tell you that 50% of my schedule today is only orthodontics, that's kind of the first thing I could say. The second part is I started treating the teenagers, and now I'm treating the parents in orthodontics, so they're coming at me. It also allows me, Ed, to, if I'm having adult patients, I can set up teeth better, and then I can finish the treatments either with restorative, with implants, crowns, whatever it is. Or sometimes I can offer the adult patient, instead of placing an implant, I'll tell them we can move posterior teeth that we're thinking of taking out. We can move them forward, and you won't need to do an implant. We just do orthodontics. Many a patient will prefer to spend 2 years in orthodontics than have an implant done in a period of 6 months. So the patient gets to choose. So that is amazing. And it's so gratifying to treat our population and give them that self-esteem that they get when they get a beautiful smile. That's that's unbelievable.
Absolutely. I to be honest with you, I think that you have the most to offer when it comes to orthodontics and prosthodontics, because if you can move a tooth into a better position to be able to accept a veneer or a crown or a bridge, my goodness, then you're in the best possible position. I only move the teeth into a good position, and then I refer them out if they need the more exotic cosmetic stuff when they get a little bit older. So if a child needs an implant, I'll do the orthodontics, create the space, and then kind of sit on it until they get to be around 16, and then refer them to have the implant done. You've got it all in your own practice.
The beautiful part is when we think about implants, we're really out of the implants until the patient is 20 to 23. So one of the techniques that I have been developing, I call it tooth replacement policy. And I will look at the teeth and I go, why can I not bring these teeth posteriorly forward and replace them with their own natural tooth? Mm-hmm. Because I just can't imagine a young teenager missing a congenital lateral and just have them wear a flipper or some kind of bonded fixed bridge for years and years and years. And it may fail. Usually, we know Murphy's Law, so it may fail when they're at a get-together, a party, trying to look impressive in a date. So why not use their own teeth to move them into the position, and then we reshape them and make them look amazing?
Well, that's part of your specific protocol. You've developed some very specific protocols in your diagnosis and treatment plan, which is a little bit different because you have so many other ways of doing things. Talk about that a little bit.
Well, I think that we always have to think that we need to adapt the techniques to the patient and not the patient to the technique. So I love the fact that we have motion distalizers, carriere distalizers, we have NPEs, RPEs, we have anchorage. One of the biggest things, and probably the biggest mistake, a lot of people will peg me as only being a TAD user. And for me, a TAD is just one more tool in my toolbox. So when
for those that are not familiar with the word TAD, let's explain that.
Yes.
It's a temporary anchorage device. Explain what that is to those that may be listening in Mongolia or China or Latvia.
What I use most of the time, there are several types of TADs, but the TAD that I usually tend to use is a screw mini implant type of anchorage. So we basically place it with probably a fourth of a carpool to give anesthetic to the area. We place it, we put the patient on Tylenol for 2 days, that's all it takes. And we basically set up a point of anchorage so that we can either pull from it or we can connect to teeth and prevent them from moving from where we want them to stay.
So it's a small screw, basically, similar to an implant, but it goes in between teeth.
It can go in between. We actually try to stay away from the roots as much as we can, so we can put it next to the teeth. Yep. Or we can put it in the palate where it does. There are areas, and I give a course on that, where you don't want to go in and start dropping them in. There's a lot of mistakes from that point of view. There are areas that are better, areas that are worse. Once you learn what are the good areas, then your next knowledge should be, okay, now that I place this spot that doesn't move, what do I do with it? How do I hold the teeth? How do I move the teeth? And so, but it's in orthodontics, we have to think of anchorage as a sliding game. You can have movement of both sides. You can have partial movement on one side, or you can have no movement. So according to how much you need to move or not move, you decide which is your correct anchorage. The other thing is you have to decide, will the patient put up with a lot of anchorage, like a headgear, or will they hate a headgear? So what are you going to use? That's where I bring my TADs in, because nobody will accept a headgear nowadays.
Well, in the American Orthodontic Society, you're the TAD man. There's not one instructor in our organization that knows more about temporary anchorage devices than you do, and you give a great course on it. You've spoken all over the United States and the world about TADs, and by far an authority on the use of temporary anchorage devices. I know for a fact, because you've shown me and we've talked about it, that you use 3D imaging. How does that play a role in the way you're doing your treatment and treatment planning?
That is the amazing question, because the answer is so beautiful. When you go to 3D imaging, you get a GPS of the patient's skull, of the patient's bones, of the patient's teeth. You get to see those roots and see, are the roots correct or are the roots dilacerated? I have a beautiful article in the JAOS that shows how the dilaceration of the teeth affected the whole diagnosis. And you have to know that to know if you're going to be able to bring an impacted tooth into the mouth, or if you have to decide, no, it's better to have it removed. And can you remove it, or do you need an oral maxillofacial surgeon to remove it? Lately, I'm also using our 3D when I do expansions. I do a lot of expansion. I do a lot of expansion with RPEs. I treat a lot of impacted canines. So one of the things that I want to do with that is be able to know, hey, how much can I expand? And the cone beam, which is the 3D imaging, allows me to see in a transverse position how much. Where am I going to do it? Where am I going to anchor? It also lets me look at all the impacted teeth and know, where am I going to position? If I'm going to go position this tooth or remove this tooth, how am I going to get there? So it just makes such a difference in that way.
Yeah, that is amazing, and I need to really beef up on my temporary the temporary TADs, because I know that sometimes when you're doing a impacted cuspid, you sometimes have to move the cuspid backwards before you move it into its correct position. And I've seen you use the TADs to be able to do that very, very adequately. I mean, it's just a beautiful way to do that.
It's part of the diagnosis that I wouldn't even think today of not using it. We talked about how I combine with Elsa, my wife, in pediatric dentistry, and you know it as a pediatric dentist that you get a lot of supernumeraries.
Yeah.
Through the imaging, I can locate the teeth for her. I can help her decide if she wants to do the surgery or if I do the surgery. Do we approach from the buccal? Do we approach from the lingual? How many millimeters do we go through the bone? All of this. So instead of doing this guessing game we used to do before, you know exactly where you're going and how you're going to do it.
Well, that's what I was telling the audience, is that I'm so impressed with the way you formulate your treatment plans and your diagnosis. But the reason that you can formulate it so differently is you have so many other things in your bag of tricks. You know, the temporary devices are one of those really, really great ways to move teeth that don't blow the anchorage or cause the need for removal of teeth. Although I know for a fact that you do extract some teeth sometime, don't you?
I think that no tooth is sacred if it's time to come out and be replaced by another. And I know that sounds very harsh. Some people are going to probably hate when they hear this. But I also know that if we listen to Dr. Nicasio was one of the people who helped me formulate that part of my treatment as to picking which teeth to keep and which teeth to take out. And tats are beautiful, but if you have somebody who doesn't have really good hygiene, they're not going to work. So that's when you have to think, well, what else is there? And we forget about wisdom teeth and how we can use them. And I still remember some of my colleagues saying, Dr. Jackson always said, do not ignore the wisdom teeth. They could be very useful. Class 2 patients is a very good example we have. Many times if you look at a good wisdom tooth in position and you look at a first molar that would give you the exact space to correct that class 2, sometimes we take out those first molars and we basically do a sliding anchorage against the second molar, and we use that space to basically retract all that anterior area and bring that second molar into a beautiful class 1.
Yeah.
And the wisdom tooth drops right in, and you don't have to do any additional surgeries. You don't have to use any kind of expensive devices. So it's a very good tool, but you have to do the diagnosis correctly. Wisdom teeth, we publish it many times. We'll take out first molars, and then we'll use that second molar, let it slide a little bit forward, bring the other teeth back, and you've got a beautiful solution. Peg laterals that look ugly, that don't work, and you have a kid that's already in a class 2. We can reshape the canines and bring things forward.
Exactly.
And we can do it with extractions.
Done that many times. It looks great. It looks great.
Exactly.
And it's a very good way to treat missing laterals or peg laterals that you might find in a young child. And the parents have trouble visioning what it's going to look like when you finally take out peg laterals and all they see is a space. But when you can close it all up, it looks really, really good.
When you close it, it just makes. Today I had a consultation, third child of the family. When I looked at the kid, and he's already molars in a class 2, so my anchorage would be with a TAD, and I'm looking at horrible peg laterals. And I looked at the lady, and she looked at me and said, "Are you thinking of doing what you did with my daughter?" And I had to go back and think, oh yeah, in your daughter, I took out the lateral incisors because she had horrible peri on them for just unknown reasons. So I took out the laterals, I moved the canines, resolved the perio issue, but the mother was already ready. She said, oh, thank God, I don't have to worry about those little teeth because they were going to cost me 2 extra crowns. So it works. So once again, we just, sometimes we get so tied into this ideal occlusion. And I think it's because we study with ideal models. And so we see ideal teeth all the time. But we got to remember the kids that come and the adults that come for our treatment don't have ideal teeth. We're trying to take what they give us and make it as good as possible.
Yeah, exactly. Now, you just don't treat children and adolescents. You treat adults as well.
I am fascinated with adults. Probably what made me, this is kind of a funny story, but I have this physician faculty teacher in the School of Medicine here in Houston, and she is 78 years of age. And she looks at me and says, "Why have you never offered me orthodontics to straighten my bottom teeth?" In my mind, I'm thinking, but you're 78, you live with them all your life. And then I think, oh my God, I am doing a bias against her because of age. So I turned around and said, "Do you want orthodontics? Let's get you organized. Let me do the records right now." And it was beautiful. So she currently has her lingual retainer, happy with her teeth straight. So after that, we don't discriminate based on age.
Well, based on what you are talking, this always fascinates me because I think it's part of practice management. But I'm assuming that you take your records first and then do your consultation.
No, and
Okay.
I do it backwards. I have a conversation with the patient. I want to know, why do they want orthodontics? What are the expectations? Then I will screen the TMJ. We don't want issues there. We screen medications, any kind of drugs, any kind of habits. We do intraoral exam, extraoral exam. I have them stand up, I have them walk, I have them talk about breathing, everything else like that. So I'm already recording all of this information. At the same time, I'm getting a gauge, am I the right doctor for this person, or do they need to go to see somebody else? So that's very, very important for me. So once we have that, then I'll talk with them and say, look, I think I need to refer you, or I would love to have you be here with me as a patient, and I can offer you the treatment. So that's how we handle it.
Mm-hmm. Okay, so then you but you don't give them a fee or a price or anything like that at that consultation, that first consultation, or do you work the case up first?
This is funny. No, I do Uberodontics, and it's a funny little term I created. I have a fixed fee for my records, so my records have a flat fee. I have a fixed fee for my retainers, but during treatment, I will quote the patient an X amount for every specific appointment. So you come to see me, and this appointment, this is how much you pay. When do you stop paying? Well, there's a cap. I'll give them a cap, and usually it's a high cap. If we finish before, you save yourself money. If we finish later, you're still paying me, because every single patient is going to be different. I'm not sure if they're going to show up. I'm not sure if they're going to be compliant or not. So I explain it to them. You make me go faster or slower. So it depends on you, how much your ortho is really going to cost or not.
And you do this with the kids as well?
I do it with everybody.
Boy, I'm going to sit down and talk with you a little bit. That sounds fascinating.
I used to have that fixed fee, and I felt unethical if I finished too early, which is dumb, but that's how I felt.
Yeah, you want to make the case take longer so you can get your full fee in, right?
Or exactly, where I worried about the fixed fee. Now I don't worry about it because, hey, fair is fair.
So you let them know up front that that's what's going to happen.
Oh, every single patient knows it up front. We don't even start until they know exactly what it is.
Yeah.
We also have a retreatment fee. If you don't wear your retainers, your teeth start moving or you grow, I have a cost for redo of records, and they know exactly how much they're going to pay. So we have both up
That's
front.
a great idea as well. I'm implementing that tomorrow when I get back in the office, because I'm having a few kids coming in and not wearing their retainers. But there are difficult cases too, and there are some cases that just take a long time. One of the things that being a pediatric dentist practicing alone, and I do a lot of orthodontics, you know that, but one of the things that I have difficulty with is those class 3 patients, because those class 3 patients sometimes take forever to treat, and they sometimes don't treat out until they're much older, and they're uncomfortable coming to a pediatric practice. So you have the advantage of working in a population where you can see the kid from pediatrics all the way through to when they stop growing.
Class 3 is very interesting. You and I know that we're going to have to diagnose the true mandibular grower, and that's the patient that should be immediately referred out. If it's a dolicho class 3 true mandibular grower, we're not going to be able to resolve it. That's going to be in the hands of an orthodontics and oral maxillofacial surgery at the end. Once we exclude that group, then that's about 5% of the true class 3s. Then we're going to look at the beauty of phase 1. Phase 1 in pediatrics is so critical for these class 3s because if you can take that mid-phase deficiency and you can grow it and grow it and grow it, but you got to remember, you grow it once, the body keeps on growing, you're going to have to come back and continue growing. So it's very critical that you do that. But that's how we handle it in our office. Elsa takes care of doing that maxillary expansion, moving, creating space, trying to prevent those canines from being impacted, which is very common in those class 3 mid-phase deficiency. And then I would like to take a break from them from the time they're like 10 or 11 until they're about 16. And then I pick them up. Because at 16, on the girls, it's a done deal. On the boys, I can do a lot of camouflage treatment. And that's where TADs are really, really important. Because at that time, they're not going to use a reverse pull face mask, which doesn't really work well in that population. But I use TADs and I do what I call an intraoral maxillary advancement. And at the same time, on the mandible, I do what I call an EDC class 3, but it's a technique that I learned from Jin John Lin out of Taiwan, and we use skeletal anchorage. And we basically do an intrusion and distalization of all the mandibular teeth. And there are certain parameters that you have to learn how much you can do. But if you're within that envelope of treatment, you can camouflage these patients to such a beautiful degree because a lot of them don't want the surgery or can't afford the maxillofacial surgery. And we can do it for a few $1,000s. We can do a beautiful camouflage treatment. They may not have.
Does it involve extraction of like lower premolars?
I have taken out very few lower premolars to handle class 3s. There's some beautiful cases doing that. I'll treat some taking out first molars, but if I have the space to distalize my second molars, my 2 set of bicuspids, the canine and the incisors, I will just bring everybody back a little bit.
Using
so
the
it
TADs.
All depends how using the TADs.
That's what's so amazing. These TADs are in the right hands make such a difference in the way you treat and the way you diagnose. But you know what? You and I are from the old school one because we do a lot of our own lab work. And I know that you make some very exquisite appliances that work with the TADs. And it all has to do with the ability to be able to bend a wire and solder and make an appliance that works in the mouth.
And you know, I learned so many things. One of them I learned from you, the touching all teeth appliance. I got it straight out of your courses to where it's a modified lingual arch as a retainer, and pretty much that we finish all of our phase 1 patients with the touching all teeth appliance. At the same time, I sat down and said, you know, I want to do a better expansion appliance. And I saw some of the RPEs, and then I said, I can probably modify this. I can get a better support. So I basically went to my drawing board, and by being able to do my own lab work, I can sit down and for a few dollars, I can design an appliance and I can test them, and without that hardship of trying to communicate to a laboratory and knowing that I'm probably going to have to pay a premium fee because I'm going off what they normally do. So allowing yourself to have the freedom of doing some lab ability and experience allows you to customize your appliances to the patient. You're not customizing the patient to the appliance. You make the appliance for the patient. And I think that's something that's so critical that we could hopefully learn and be able to do, because it's not that difficult. It's not that difficult.
Isn't. And we've often talked you and I about putting on a course on doing lab work because you know, they teach a little bit of it in dental school, but they never really go into the way you do it in your office and how much money it can save you. Thousands, I mean, hundreds of thousands of dollars after you've been in practice as long as I have, and doing my own lab work. It's just, and now I've taught my grandkids to do the lab work in my office, and they do a fantastic job of doing all my natural appliances that we normally use.
Well, that's a good idea. And since I have a 14-month-old granddaughter, I think I'm going to teach her how to do lab work fast
You got a
before she
little bit
gets
of
other
time to
ideas.
go there. My grandkids are like 20 years old, so they're doing good. They're doing good. But and you and Elsa use quad helixes. You do MPEs, titanium palatal expanders, and you do RPEs. And that is, and I'm assuming you make some of those as well?
The NPE is the only appliance that we buy out of the box.
Yeah.
And it's amazing. And Elsa has put beautiful courses on how she uses the NPE in that phase 1. But more and more, as we manage impacted canines and we look at the transverse issue and we use the 3D imaging to see how much we have to expand, we also do the SIMS analysis, but the 3D also gives us that total bone relationship. And then that's when I look at canines, angulation of canines, and say, the literature is telling us that we have to create the space for these canines to come in. And our true workforce for that, it would be an RP.
Right.
By doing our own lab work, we can do an RP and then come back with a quad, or we can put an NP if you want to fine tune eventually, where you do a reverse Nance. So, but that's what it gives us, knowing different tools, and we can apply them. We get amazing results, and we get them in the time they want to. So it just makes sense.
Well, to the GP that's out there that has been listening to our conversation, they might not have bought into some of the names and techniques and theories and treatment plans that we use on a daily basis. But, we were just like you. If you have not taken an orthodontic course from the American Orthodontics Society, then you're not going to know too much about some of the things we're talking about. But I promise you, if you start to take the American Orthodontic Society courses, this will all start to come together. And what advice would you give to a general dentist or a pediatric dentist that thinks they might want to, start doing orthodontics? One,
you want to start learning orthodontics by people who want to teach you. The American Orthodontic Society for me has been such a well of beautiful knowledge and organization, because you can know a lot, but if your ideas are not organized, they're useless. So you have to go with a group that is going to help you get organized, that will teach you step by step. Because when I started all of this, I remember I used to read the manuals and the books, and I said, my neurons have to be pushed until they connect. And when they connect, they can see the big picture. And it's funny because I used to say, well, I'm thinking in 2 dimensions. Now I can think in 3 dimensions. But it's because of the framework that has been given to me. And then based on that, I've been able to expand on it and create a philosophy and techniques of work, of diagnosis, treatment plan, and work that allow me to do what I do today. So if you find in the shortcuts, I wish I would have known that 15 years before, earlier than what I did. I wish I would have started this in the 90s. But I didn't have that group that would take me by the hand and guide me straight to what I needed to know, give me the shortcuts. Because there's a true sense of community. It's not driven by, well, we want you to learn one appliance, or we want you to always do it this way because it's going to be favorable to that group or that manufacturer, that product. You need to know how to do this. You need to know many ways of approaching the problem, because one way doesn't always work. And that's what we get. That's what we get from learning orthodontics through the AOS. Yeah, it's just amazing.
It is amazing. I've come on to Orthodontic Smiles Podcast so many times and talked about the AOS and learning orthodontics. And I started this podcast tonight with you, and I said, you're going to be impressed by our guest tonight, Dr. Juan Echeverri, because we have gone through a list of things that I wanted to bring out in him, and he has, in an exemplary manner, really enlightened all of us in what we can do and how we can excel in our practices using orthodontics. So, Juan, I want to thank you so much for being on Orthodontic Smiles Podcast. This is one of our best. I knew I've been saving you after I talked to Elsa and did her podcast. I said, give it a few weeks, and then I'll bring on Juan, because I know what Juan has to offer as well. What a team you two are, and I thank you so much, you and Elsa, for being members of the American Orthodontic Society, being leaders in the American Orthodontic Society, and being educators in the American Orthodontic Society. So thank you so much for being on Orthodontic Smiles Podcast. Juan Echeverri.
Thank you so much, Ed. If you allow me, I'm going to just plug. We're going to be in September. The AOS has an annual meeting. I will be talking about impacted canines and how to manage, when, how, and when not to. So I would hope to see everybody that listens to the podcast come to the San Diego, be with us, see what we are all about.
Yeah, and you can get all that information on www.orthodontics.com. That is the website for the American Orthodontic Society. And if you're interested, you just look up that website, and it'll give you all the information. Thank you so much, Juan. I'll see you in San Diego.
It was a pleasure. Thank you to everybody.
This is your host, Dr. Ed Gonzalez. I want to thank you for listening to Orthodontic Smiles today. If you enjoyed our broadcast, please click the subscribe button. We'll be in touch with you in the future about our further broadcasts. Thanks for listening.